Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
She got for example, she started the Multidisciplinary Global Health Initiative uh, for faculty, students, and postgraduate physicians in Haiti, and expanded it to include all disciplines of the health sciences. And that, along with the fact that she got a special award for what she's accomplished, and made presentations about health disparities, global health disparities, so that I don't want to, if I took time talking about all of our honors, that would be taking time from her presentation, which I don't want to do. So without further ado, I want to introduce you to a good friend and outstanding colleague of mine, Dr. Shelly McDonald-Pinkett.
Well, thank you, Dr. Callender. I really appreciate that. And it's such an honor to be in front of this distinguished group this morning. So Dr. Callender talked about some of the things that I've done since I've been here at Howard. And I should let you know that one of the very first presentations that I gave when I arrived here at Howard was with Dr. Callender on his radio program. I don't know if you remember that, Dr. Callender, but
that's a long time ago.
That was a long time ago, and we talked about
right.
drug and some other things. And then, and this is also important or an interesting fact. I don't know if you remember that the O.J. Simpson episode was ongoing during one of our conversations. So it just made for an interesting memory at any rate. So
yeah, I'd forgotten all about that radio program.
Oh my goodness, no, how could you forget about that? It was great. It was great. So I actually don't know everybody's background here. I know everyone is quite distinguished in your fields and in healthcare. I did watch the recording of your last meeting, and so was able to follow some of your discussions of articles that have been presented to the group. And I know that there were a group of articles that were included and sent to me on the last email that I received. So I'm not quite sure the format, if we're going to discuss those or not. But what I wanted to talk about, because of the discussions that you've been having, is a bit about proactive medical care and preventive medicine. And I'm hoping that we can have a dialogue as opposed to a formal didactic presentation. But just to remember some of the tenets of preventive medicine, you all know that it's a broad branch of medicine that looks at preventing disease, disability, and death by taking a proactive approach to medical care. Very specifically, there are a lot of different models of preventive medicine. The most familiar is the primary, secondary, and tertiary prevention. But that's actually been expanded a little bit more, so we can talk about some of that. But what I want to point out to you from the U.S. Preventive Services Task Force, a task force made up of physicians, nurses, healthcare professionals, wellness coaches, that reviews the data to give very specific recommendations for preventive care. And these recommendations are all evidence-based. So I noticed that some of the articles, sometimes they're really opinions, and opinions based on the person who's written it, but may not exactly be evidence-based. And so those evidence-based articles and evidence-based recommendations are what's probably most important to follow, because we know that it's been proven that they are the ones that help prevent disease. So the U.S. Preventive Services Task Force, though there are many others as well, American College of Surgeons has recommendations, American College of Physicians who are mainly internists also have a number of different recommendations, but the Preventive Services Task Force with the evidence-based recommendations makes recommendations for, of course, regular medical and dental checkups, to know your family and your genetic health history, to stay up on all cancer screenings, of course, and then there's a specific recommendation for vaccination. But to talk a little bit more about the models, remember the first tenet of proactive care is for universal prevention. And that's, some call it primordial. I don't necessarily like that term, but I think a universal preventive measures are quite important. And these are the strategies that are utilized for the entire population. That's everybody. They're not risk specific or specific to age. And that's evidence that's likely to benefit children, adults, males and females. And these are things like the diet and exercising to avoid areas where there's significant pollution. And of course, what we're dealing with now, evidence of treating and screening for mental health disorders, looking at those social determinants of health. All of those are part of the universal preventive measures. And now, of course, Dr. Callender mentioned Haiti, but violence in our communities is also quite important to prevent as much as possible, looking at those areas where we can do that. So in some time ago, 1964, oh, I'd rather see everybody. Yeah, I was seeing me. Okay, that's good. In 1964, Kaplan looked at very specific targeted preventive measures. Those are the primary, secondary, and tertiary preventive measures. And those are specific tenets of public health. But what they do is look very specifically at a group of people and their risk that they may have, look at a specific, perhaps ethnic background, and risk that might be risk of medical illnesses that are present because of those specific risk factors. So we talked about the universal preventive measures and those that are beneficial to the entire population. But now when you move into primary prevention, you start talking about wellness of a specific population and health promotion for that population. So in primary prevention, there is intervention before there's evidence of any disease or injury in a specific group of people. So that's promoting good health habits, diet, exercise, smoking, of course, vaccination, and behavior management. But it may also include screening for specific genetic predispositions, and those might be included in primary prevention as well. Behavior management. So we'll have screening for depression, screening for anxiety, included in primary prevention. So after primary, of course, and all of these, they really overlap a bit. And so professionals in preventive medicine and public health have always been concerned that there's no real clear delineation between the two. There's a lot of overlap, but in general, these are the models that are prescribed. In secondary prevention, these are very central to specific risk factors. So for instance, if someone has a family history of colon cancer and a colon cancer occurring before, let's say, age 50 or in a young age, we know that those persons need to be screened for colon cancer at an earlier age. And as I was talking about looking at evidence-based practices, we know that the screening now for colon cancer has changed from greater than 50, greater than 65 years of age to 45 and older for very specific populations, because those populations tend to have colon cancer at an earlier age. And that's Black folks, and of course, people who may have had a family history of colon cancer. So secondary screenings are recommended. Also, for example, smokers. Now the screening is recommended for a CT scan, and Medicare is paying for that for those who've been smokers to screen and detect early any signs of lung cancer. So those are examples of secondary screening. Hopefully, to detect any disease at an early stage so that it can be treated appropriately, and to identify any disease at its most early stage and before it becomes symptomatic. Next, we talk about tertiary prevention. Now, tertiary prevention, hopefully, we've been proactive and we've done all of our universal preventive measures. We've done all of our primary screening and secondary screening. But sometimes we do, and we all know this, encounter disease at a little later stage. And what the goal then in tertiary prevention is to prevent the disease from causing debility or disability or death. And so in tertiary prevention, this is where all the treatments come into place so that we can make sure that persons who do have a disease that is detected at a symptomatic, maybe at a later stage, receive all the appropriate treatments to prevent that disease from causing further disability and death. So these are all the medical interventions and surgical interventions that may occur at this stage. And that's considered tertiary prevention, preventing death and disability. Now, our nursing societies have recommended that there be a fourth preventive measure, not necessarily related to disability, death, or disease, but related to over-medication, polypharmacy. And this is something that happens when, for lots of reasons, but mainly because there may not be a reconciliation of medications that persons are using. So if maybe you see your primary care physician, you might see your cardiologist, might see an endocrinologist. And if each of those specialists don't know what medications folks are taking, it just gets added on and additional add-ons. And that's where polypharmacy comes into play. And that is a cause of a significant amount of disability and illness, especially in our older seniors and our older populations, and those who are not able to follow along with what medications. So for that preventive measure, we always ask that everyone have a list of all of the medications that they take, that they share them with every physician that they see, and that the physician and the patient review all of those medications at every patient visit. So that we can help to prevent that polypharmacy from occurring. Now, I just want to go a little bit more about the U.S. Preventive Services Task Force, because I know that everyone hears all these recommendations of what you should do, what you shouldn't do, what medications you should take to help, excuse me, prevent illness, and especially things like vitamins and mineral supplements. Well, unfortunately, though we all have our favorites, but the U.S. Preventive Task Force specifically looks at the evidence. And if the evidence and the research is not there to support vitamin, minerals, or an intervention, they do not make recommendations. So what you will see are a letter grade, A, B, C, D, and I. A, recommendations mean that the research support the intervention or the medication or whatever, screening or counseling. Those are, and that the evidence supports it, the research supports it, and everyone in the task force, which is a multidisciplinary group, agrees for those recommendations. If a recommendation of B, that means that there's some support, moderate support for the recommendation, but all of the evidence does not always suggest that the intervention should be utilized. So, but most agree if a grade B has been given for a recommendation. C, now that's where the patient and their physician work together to determine whether or not they should follow the intervention. And that's probably where most things fall. It's really based on clinical judgment. So a physician and the patient may decide that it's best that they take a specific medication based on the individual's physical condition, but there are not specific research or evidence that supports that intervention globally or for a population. If a recommendation of D is obtained, that means there's they do not recommend it at all. That doesn't mean that there's evidence that the intervention could cause harm, but it means that they just have no recommendation. And it's a do not recommend. And then if there's an I, that just means there's insufficient evidence. So remember, this is all evidence-based, research-driven. It does not mean that the patient and their physician individually cannot decide on a clinical intervention, but that there is just not enough insufficient evidence to determine whether or not that should occur. Now, so just quickly, let me run through some of the preventive measures that are recommended. I know that you have many of them. I saw in some of the articles that were sent to me. Colon cancer screening is definitely recommended, and the age has changed from 50 to 45. So every young 45-year-old should start their colon cancer screening. Now, if there's a family history of colon cancer, the screening should start 10 years prior to the age at which that family member had colon cancer. I'm sorry, I see a hand raised from, yes, sir.
Yes, doctor, how much research is done on non-pharmacy products like supplements?
Yeah, excellent question, and not much. And that is exactly the problem. I think there have started to be some research on non-pharmaceuticals, but there really is not much evidence-based research on supplements. I can tell you one that there is quite a bit of research on, and that's vitamin D. But the evidence is really mixed. in relation to that. So the Preventive Services Task Force has recommended that we even stop screening for vitamin deficiency. Endocrinologists, however, might have a different opinion, and that's where this gets a little bit tricky. The endocrine societies definitely recommend vitamin D. The task force does says that there's insufficient evidence. So it's a little bit of a mixed message there, but I'm going to speak strictly about the U.S. Preventive Services Task Force, because it's such a huge group, and they try to gather all of the evidence and research all of the data surrounding specific interventions. So there is not much. I hope that answers your question. Okay. Answers your question with a lot of other questions. We could always say for most of these things, more research is really needed on those things. The other, sometimes a little bit controversial, is prostate cancer. Now, we know that in our African-American males of color, prostate cancer is still a significant cause of death. However, the task force has found that it's a decision to be made between the patient and the physician. So it's a level C whether or not those PSAs should be done. And B, for African American males, there is some evidence to support screening with a PSA in younger, I'm going to say younger, but that means about that 50 age range males. And in seniors, there's just really not evidence that performing a PSA is helpful. I think in my practice, because of who I see in my population, I do screen for prostate cancer, and that's where the clinical judgment comes into play. So it's more who that person is in front of you, and what working together with your physician to determine what should be done. The other aspect I'd like to talk about, besides the cancer, and we know mammograms in women, of course, is still a recommendation at age 50, but to stop at 75, because there's no evidence that after 75 it's beneficial. Now, in clinical practice, however, I do mammograms in 75 and older, depending on what their wellness level is. So if I have a very active 75, 80-year-old patient who has another 20-year lifespan, yes, we do those mammograms, because if we find something early, we're able to treat and manage. Yes, sir.
Okay, going back to the PSA.
Mhm.
I have a history in my family. My father and my son both had prostate cancer and were treated, I guess, successfully for it. But my doctor, and is there a reluctance to give the PSA? I mean, is it expensive, or what's the deal? Why don't they want to give it?
Right. So I'm going to answer all of these questions based on the task force. I have my personal opinions too.
Okay.
All right. The task force says that they do not consider cost in any of their recommendations, strictly based on the research and whether or not it's shown to have a benefit to the patient and the population that they're looking at. Now, for your specific case, there sometimes is a reluctance, because the question is, well, it's elevated, the PSA, let's say it's elevated. Well, what do you do with it? Do we give you medications that may make you more uncomfortable, add more risk than the actual elevation of the PSA? Because prostate cancer is one of those that it really takes a long time before it causes morbidity or mortality. And so it's very slow growing in most instances. So that's why there's that reluctance to do that. So it's the PSA has to be followed over years. If you start to see it increase, then increase without symptoms, which is pretty much unusual, then it's a determination of whether or not to intervene at that point. If the PSA is elevated and there are urinary symptoms, difficulty passing urine, that sort of thing, then the decision between the physician and the patient may be to intervene. But the PSA elevation itself does not mean that there's a malignancy present. The PSA means that the prostate is likely enlarged. Yes, sir. Did that
I'm
get to
sorry.
your question, Mr. Buchanan? Yeah.
Yes, thank you very
Okay.
much. Thank you.
Yes, I see another hand.
Yeah, it
Uh,
was mine.
oh,
I'm sorry,
yes.
I was a little slow to get to the unmute button. But about prostate cancer, I was just wondering how much there's discussion there's been about either non-lactose persistence, lactase persistence. It's typical with Black people, uh, and the relationship between that, dairy, and prostate cancer as far as prevention. Because I see some articles that conclude that there's no relationship between non-lactase persistence and the risk of prostate cancer, but there's other evidence that shows that dairy consumption increases the risk of prostate cancer, and there's evidence to say that a strict vegan diet reduces that group is 35% less likely to develop prostate cancer.
Right. So it's really interesting, the impact of diet on malignancy. But I can tell you that there is not enough research in that area for them to make a very specific recommendation along that line. Now, we do know that those who prevent, I'm sorry, those who recommend a vegan diet, and those who are vegans, especially those in those oh, I apologize, I need to turn this off. Elizabeth, I'll call you back. I apologize. Those who need to, that's my Haiti group, actually, Dr. Callender calling. But those who follow a vegan diet, we know that they are sometimes less prone to malignancies, all malignancies. Those whose diets are and whose body mass index is lower tend to have less malignancy. Now, can I tell you if there's a specific relationship between dairy and prostate? I cannot give you any information on that based on the evidence that I'm speaking about today. But I do know that those who follow a vegan diet tend to have less malignancies. That's breast, prostate, colon, as well. We do know that those who eat more red meats tend to have more malignancies. So there is a relationship, direct relationship, causal relationship that unfortunately I can't speak to. But I could probably look more into that and get back to you regarding that. Is there something that you would like to share more about that?
No, that was just a question about the research.
Yes, I understand. Okay, thank you for that. But I can speak in a little bit more in generalities about the vegan diet. We know those who live in blue zones, those in the United States, it's in Loma Linda, in Japan, and some of the other blue zones where folks are living well into their 200 years, mainly follow a vegan type diet. some Mediterranean diet, but those blue zones definitely are following those diets, and they have less malignancies, less heart disease, and less diabetes, and they tend to have a lower body mass index. That I can let you know is absolutely true. Any other questions about the malignancy? So interestingly enough, the task force recommends screening only for those three: colon, lung, and breast. So the research, despite everything that we know, supports screening for those. Ovarian, cervical has changed. The screening for all of that has changed, and I'm speaking mainly for adults. That has all changed. The one thing that I also want, if I could move on to cardiovascular, we certainly know that the vegan diet and a lower body mass index decreases cardiovascular risk, but the task force has actually made a recommendation that statins, Lipitor, Crestor, rosuvastatin, and atorvastatin are added as a preventive measure in folks who have any cardiovascular risk and a 10-year risk of heart disease. The evidence now has proven that adding those statins to the medication regimen decreases those risks. So those are patients who are diabetic. So now all my patients with diabetes, hypertension, other risk factors should be started on a low-dose statin to help prevent cardiovascular disease. And I saw in the information that you sent a really nice run sheet from, I think it was Asbury, about hypertension. And that's very beautiful. I love to see that the churches are involved in preventive health care and promoting education around health care. So quite good to see that. Now, as far as infectious disease, and Dr. Callender, you have to tell me about my time. You know, I could talk on forever. So am I okay?
It's your show.
Oh, okay, very good. I love it. Thank you for that. To talk about infectious disease. Now, I took a quick look at RSV because that's in the new old game in town. But the vaccination is recommended, especially for those 60 and older who have any kind of pulmonary or immunologic deficiency. So RSV vaccination is recommended. It's an antigen, so it's not that RNA, DNA, all those things that everybody was concerned about. But for those who are at risk, there is a recommendation. RSV usually is in little babies. You know, you hear about it in the children. They really have difficulty breathing. But what has happened with RSV now is that we're seeing it more in seniors who have immunodeficiencies or who are at risk. So that is a recommendation for RSV vaccination. Has anybody had it? No, not yet. Yes, okay, very good. The other, now the task force doesn't speak much about vaccinations because there are so many. The CDC is controversial as that has become, but there are recommendations for vaccination from the CDC, and we know them all. Yes, sir.
Okay. What was your question? Did anyone have RSV or the vaccination?
Did anyone have the vaccination? I'm sorry.
Yeah. Okay. So I had
Good.
as well.
Oh,
Yeah.
good. Okay, very good. Very good. And you know, vaccination is always a little, I won't say controversial, but folks usually have a lot of questions about vaccination. Vaccinations are definitely a preventive measure. We know that polio was almost eradicated with the vaccination. Smallpox can be, measles can be, if our populations were vaccinated. there is a lot of misinformation about vaccination, and it's really difficult to counteract uh, that information. I know, that you know what's going on TikTok and the news these days, and all of the other social media. And but and especially with the influenza vaccination, I can remember my grandmother saying, "I'm not getting that flu vaccine. I got sick when I got it." And it is true. It may make you feel ill. Um, that can be counterbalanced with Tylenol and that sort of thing, because the vaccination, um, all of them act almost like the illness, except it's a muted form. That's probably the better way to say that. And what it does is causes the body to produce its own antibodies to so that if the bacteria or virus enters the body later, the body can on its own counteract those viruses or bacteria. So the ones that are recommended, of course, flu every year, Pneumovax at 60 and older, the RSV older, older than age 60, and of course COVID. Now COVID is the one that's been most controversial. Yes, ma'am. Oh. Mhm.
You had mentioned about the antibiotics and the um, injections that you receive. Is it any way that you can build your body up to accept the injections for COVID and other injections to better, how can I say it? So that your body will better accept how that drug is going to react in your system.
Okay, I think if you let me know if I'm off course. So we did hundreds and hundreds of vaccinations during COVID. And what we recommended to those that to help prevent some of the side effects or feeling bad after getting the vaccination for certain things. Knowing that at the injection site, there might be discomfort. So we recommended heat and movement and exercise to help counteract that discomfort at the injection site. First of all, everyone who received I'm going to talk about COVID because that's the real deal that everybody's concerned about. So number one, when I give a COVID vaccination, nobody leaves the office for an hour. They sit, they massage, they apply heat. For those who have had COVID vaccinations before and may have had, I'm going to say, an exaggerated response, meaning because you will feel sick, you'll feel tired, you may feel a little bit achy. We recommend Tylenol for those who have to kind of counterbalance that feeling, and hydration and rest. So the day after the vaccination, we say don't make it a Friday if you're working, so that you can have Saturday off to rest. You don't do the vaccination and then go do all your shopping and go to work and all these things, because you will feel it. You'll likely feel bad. But the thing about it is that goes away 24 to 48 hours. COVID itself does not go away 24 to 48 hours. So we want you to get through that initial discomfort after the vaccination by taking, drinking lots of fluids, hot tea, exercising, mild exercises, so that next 24, 48 hours, when you're feeling uncomfortable, to help alleviate some of that. The problem, though, remember COVID, and I have to say, I guess I want to counterbalance the two. The feeling you get after the vaccination and what happens with COVID. COVID can last for weeks. We know it affects the lungs. And then those who unfortunately may have long COVID, which lasts for, we don't know, but for years, seems to be the thought. So to build up, yes, I understand what you're saying. Those who are healthier do better with vaccination, any type of vaccination. Does that kind of get to your?
Yes, it does. One other question. Food intake, the day of, should you lessen the amount of food that you eat, or does that have any impact on the vaccination and how it works and,
Okay.
and the results?
Yeah, no, I would say no to that because the day after you may not feel like eating too much. So the day of, yes, have your normal meals, what you would usually do. I always recommend a healthy meal, not too fatty, because fatty meals sometimes can cause a little nausea. So things that are, the more fruits, the vegetables, the soups and things like that, but nothing too heavy before the vaccination to help prepare for it. Yes, ma'am.
Thank you very much.
Oh, you're welcome. That's a good question. But I want to hear, if I could, from you all about the COVID, because it helps to inform me when I talk to others about what they're hearing about the COVID vaccination and should you do it, should you not do it, and that sort of thing. Yes, sir.
Okay, so I'm 74, I think, and
Mhm.
they said that this new COVID booster is up and we should get it. What's your take?
Oh, yes, definitely. Hopefully you've had the other COVID vaccinations, and the
Yeah.
23-24 COVID vaccination is an update to the others, and it's thought that it would it's the thought is that it would last for the entire year. So yes, I definitely think that the 23-24 everyone should get if you have not done that one. Are you all still hearing folks who are reluctant to get COVID vaccinations?
What about the CDC request that you get another booster now? What are your
Yes,
thoughts about that?
yes, definitely. That's the 23-24, the updated Pfizer vaccination. So yes, that is the 23-24. That's the last, that's the newest one. And the thought is that that will last a year. It is likely that COVID vaccination will become almost like the influenza vaccination, that the recommendation is for that to be done yearly. Yes, sir.
So if I got if I got my last booster last November, then I should have the latest. Does that mean I'm good?
You did your last booster in November, so it is time for the updated one. If you have not had the 23-24 update, then yes, you would do. Yes. So, well, good. I know this is a well-informed group, so I know that some of that misinformation about the COVID vaccine and others, I know that we are able to counter that when we talk to our friends and family. COVID is still here. We are still seeing those who are becoming positive and becoming very ill with the COVID vaccination, but it is certainly still recommended. Okay, I'm going to move on from, I think I have a little more time, to injuries. Now, this is an area that also impacts so many people, and the injuries are that there is a recommendation that we counsel about is around falls. I always tell my parents, my mom's 92, my dad's 94, that the word fall is a bad word in our house. Nobody's allowed to fall. You can do a lot of other stuff, but you cannot fall. And the reason is after a fall, there is so much, usually disability and rehabilitation required when an older person falls. If there's a risk of hip fracture, and I think there's also something psychological related to that. It's almost people become fearful. So they change what they do every day related to the fact that, oh, I fell, I'd better not go outside anymore. And so your whole mindset can change with that. So you have to be very careful with falls. So that means things like those beautiful scatter rugs people have in their homes and runners and anything like that. It should be just a bare floor or bare carpet. Those flip-flops and slippers, um, that you wear when at night or around the house are really dangerous. Have to be careful with those. It should be a full sneaker or tennis shoe. I don't recommend anything like that and as we get older. I remember reading an artist, I forgot his name, he's in his 90s, but he said, someone said, well, what do you do every day? He said, the first thing that I do is make sure I don't fall out of the bed when I get up. Make sure that the sheets are in the proper place and make sure that my feet are solid on the ground before I get up in the morning. And it's really important. So falling, hitting your head, hitting any part of the body can be quite dangerous. Oh. The other is to talk about really quickly is mental health. And I want to talk about that in relation to families, our seniors, but especially in our young people. I think that the social isolation, the social media, the failure to interact person to person, in person, has taken a toll on the mental health of some of our young people, especially as they're developing. And so I think this is an area where our churches, our schools, our social organizations can help these young folks be more adaptable to life circumstances by having closer connections with them and providing opportunities for them. So mental health counseling is the number one item that comes up when adolescents talk to their physicians. It's either around bullying, feeling safe because of the violence in our society, safe in their homes, that sort of thing. The other is for our persons who are maybe living alone, to make sure that we maintain social interaction. Now, one of the things that's great about our platforms, like Zoom and Teams, is that we can come together and it can eliminate some of that social isolation for for our seniors. But for our younger population, they have yet to learn how to interact one-on-one. And so they have a little difficulty navigating that space. The other thing, vision and hearing, that's the last place I'm gonna talk about with that. Vision and hearing screening is recommended for everybody 60 years of age and older. We know that visual changes sometimes come before cognitive impairments. So folks who are not able to see well and there's some changes and they start to become more isolated, that can impact the memory and cognition. The same thing with hearing, not understanding what's happening and being able to navigate in the world can also cause cognitive impairment. And since I said cognitive impairment, there is no recommendation for screening for cognitive impairment. I know, you hear these saying, oh, should I have a memory test? Should I have all these things done? The evidence doesn't really support that. What they do support, however, is social engagement for for everybody, young people, older people, and to make sure that family ties, et cetera, or social groups are maintained. And so and I'll say this is one of the great things about this. From all the articles I read, I said, wow, this is great because it stimulates the brain, stimulates thought, stimulates conversation and new learning. And that's what helps as far as cognition is concerned. So I'm going to, I think I'm going to conclude there and say that just to remember, as far as preventive medicine, preventive health, and being proactive in healthcare requires counseling about the things that we talked about. There are some medication interventions, especially for the statin. That's the one that's new, and vaccinations, and then to make sure that the appropriate screenings are done. I know that everyone challenges their physicians, and I shouldn't say challenge, I should say partners with their physician and their healthcare team. Ask all the questions that need to be asked, right? Take notes, write those questions down before you go to, appointments or before you're engaged with others to make sure that everyone obtains the knowledge that's required. So I'd like to stop there and see if there are any other questions or anything else that we can talk about. I was hoping we'd
Yeah,
talk about some of those articles. Yes, sir. Dr. Callender.
Well, I saw
Oh,
Yeah.
yes, Mr.
Yeah, I had a question going backwards. Thank you for a wonderful presentation, though, by the way.
Take it off when you're not talking.
Very, very informative. Wanted to go back to the screening for
Yes.
lung screening. I have read that they ask patients sometimes, are they currently smoking? And then sometimes they ask, well, have you smoked in the last 15 years or the last 30 years? Or it was a childhood or whatever, smoking. So when it comes to screening for lung cancer, those different time frames, do they play a role in the screening process?
Okay, good. Excellent thought. So the thought is that every 10 years that a person has not smoked, the risk for lung cancer decreases. So that's the reason for asking those time frames for smoking. However, every smoker should have, smoker or former smoker, especially for the last, someone who smoked within the last 25 to 30 years, should have lung cancer screening with a low dose CT scan at least one time. Current smokers, of course, are counseled to stop smoking, but their screening is more frequent than that. But every smoker who smoked in the last 25 to 30 years should have had at least one low dose CT screening. And here's the interesting thing about that. Medicare is paying for that now. Medicare is paying for that. But some of our patients who may have some of the Medicaid HMOs are not paying for that. So we've had to really advocate for those, and they may be younger, not Medicare eligible. Really advocate for that screening for those who fall within that population.
Thank you. That answered my question. Thank you.
Okay, very good. Ms. Joyce?
You're muted, Joyce. Joyce is muted.
Okay. Hello?
Yes, ma'am.
Okay, Carol.
Okay. I was wondering as far as falls, preventive falling. A lot of times seniors, their legs just give out or a knee will give out. What's preventive? There's no scatter rug or anything. They're just walking and a leg or knee goes out. What's preventive for that? Would a knee brace or something like that work?
Okay, very good. So a couple of things. First of all, if the knee gives out, that usually means that the muscles that support the knee may be a little weak. So that's the muscles in the front of the thigh, back of the thigh, and in the back, the calf, and the back of the leg, in front of the leg. So what the preventive for that is really exercise. That's the bike, walking, and the motion, the repetitive motion of bicycling is helps for that. Now, we can't prevent everything, and sometimes that will occur. So if the knee buckles or gives out the first time, what we're going to prevent next is the second time. That means the first time that happens, someone may need an assistive device, a cane, and to have evaluation of their gait. I hope you're not driving. To have evaluation of their, oh, okay. To have evaluation of their, how well they're walking, and to have an occupational physical evaluation of the leg to make sure that those muscles are remaining strong. Okay. Yes, ma'am. Ms. Joyce.
Okay, I think I'm ready now. I also want to thank you for your very detailed and educational discussion that you're having with us. I was listening to a conversation with some friends regarding vision and what it means to have 20/20 vision, 20/40 vision. Can you explain what those numbers mean? Because now I am thoroughly confused.
Oh, yeah, me too. So those numbers really are reflective of the distance that someone requires to see the same thing. So it's a corrective number. So someone who's 20/20, they can see something at 20 feet, right? Someone who's 20/40, that means they need a correction to see that same distance that someone with normal vision would see at 20 feet. Okay, so their corrective lens would at 40 feet would need to correct to that 20 feet. Does that make sense?
Yes, makes a lot of sense.
Okay, so
Okay.
it's about the distance and the changes in distance to be able to visualize something.
Okay.
So that is the corrective measure for the lens in their glasses.
Okay, thank you very much.
Okay.
Is there no, oh,
Oh, I
John,
see
did you have,
another.
John, did you have another question?
I've got three questions.
Oh, good.
Okay, so going back to the former smokers, I quit about 30 years ago smoking. So is there a recommendation for me to have a CT scan?
So I hate to be prescriptive because, all of those rules around the patient-physician interaction. I would say to have the conversation with your physician to determine whether or not you should have a low-dose CT scan. Having said that, if we had that relationship, I would do a low-dose CT scan for you.
Okay, so I had a fall. It was outside of the house, and I fell off of some stairs, brick stairs, and fractured a rib. And it was I think rib number 10 or something. It was a floating rib. It was only attached in one spot, and it only hurt when I laughed, right? So after about 3 weeks, the pain went away, and I guess it healed. They did an X-ray to make sure that there wasn't any impact on the lung, and they saw a spot on my lung, but they said it might have been a shadow from my breast. Then they redid the X-ray and put a cover over my breasts, and there was no more shadow there. So I was wondering, would that indicate a need for a CT scan?
Well, again, and I'm going to preface everything with, I think it's a good idea to have that conversation with your physician. But it sounds as though that was evaluated appropriately, and may not be an indication if those shadows were no longer present.
Okay, and lastly, okay, I know I have hearing loss. I know that it's a fact. People have told me I need to get a hearing aid. And I've got mail, text, email from here.com saying, that their hearing aid is so good and it's really less expensive than the ones that my audiologists have recommended. I mean, they're talking thousands of dollars, or $5,000 per ear, and I'm going, hey, come on now. But being a musician, I know about frequencies. I know that they would take a test of my hearing range and adjust that hearing aid to my specific hearing prescription. What about those cut rate hearing aids
Yeah.
you can get for $300 or $400?
Yeah, that's a really good point. So here's my thought on that. If there is hearing loss, it's because there is a requirement for amplification. So I cannot tell you that the $300 amplification device is as good as, so to speak, as the $5,000 one. But I can tell you that the $300 amplification device will probably work. So, it's best to, of course, follow the advice of your audiologist and your ENT. But those devices, some of them are extraordinarily expensive. And the interesting thing is some you can tune using your telephone, your computer, all kinds of interesting things to help increase the hearing ability and the capacity of those devices. So I depending on the severity of your loss, you might just do well with an amplification device. Um, and then, if you want to really, really fine tune and you have $10,000, go for it.
Wow. Thank you.
Yeah,
Yeah.
John, I went through that process on getting my hearing aids, and I tested the cheap ones and the expensive ones. I can tell you that most hearing aids are optimized for speech, not music. And I have a lot of musician friends with hearing aids. And it's going to be the more expensive ones that are optimized for both music and speech. A lot of the cheap ones, I've had friends that have tried the cheap ones. They have to take them out when they want to either hear or do music because they make music sound terrible. As a musician, your only reasonable option are expensive hearing aids. So just get over it and get yourself down to some place where you get some decent hearing aids so you can get on with your life. And
I like that.
but yeah, uh, back to vision prevention.
Yes.
Okay, I just wonder how much research and what the conversation is about the effect of high blood sugar over time, because that can damage the blood vessel in the eyes, change the shape of the lens, and make vision blurry. So how much discussion is there about how much prevention effect there can be by either moderating or eliminating sugar in the diet?
Oh, oh, moderating or eliminating. I can talk about moderating. I can't speak about eliminating. There is certainly a number of studies that show the impact of high glucose level and the glycemic index and the impact on vision. So that's well known, well studied. So it's really is it the diet? Is it just controlling those glucose numbers? So those who are type 2 diabetics, whose elevation in the glucose is diet related and can be diet controlled, absolutely. The less glucose sugar there is in the diet, the more ability to control what happens with the vision. Those who require medications to decrease that glycemic index, the medication as well helps to protect the vision. Those who are type 1 diabetics and require insulin protect their vision only by lowering the glucose with intervention, meaning medication. So absolutely, the diet certainly helps those who have a high BMI and high pre-diabetic or are diabetic. Decreasing the amount of glucose in the diet is extraordinarily effective in helping to protect the vision.
I know this is anecdotal, but I was a glasses wearer for about over 40 years with a vision of 20/70. And when I eliminated sugar from my diet in the early 2000s, over a course of a couple of years, my vision went to 20/30, and I no longer wear glasses. And I passed my driver's tests, vision tests, with, well, let's see, my vision has been measured at 20/30, and I don't need glasses. And I can drive, I can read, watch the computer, I can do everything without glasses.
That's excellent. So we do know that diet impacts, and most of it is information that we know. We know how diet impacts the body, without question. And so those who are able to control their diets generally have less disease, morbidity, and mortality, without question. So that's excellent. And I did see a vegan article in I think in some of the information that was sent forward. But I think would be really great for the group to look at those blue areas and how those folks are living their lives. Those who are living to be 100, monitoring their diet, their exercise, their lifestyle. It's what's most important. Many are still very engaged in civic activities, their churches and groups, and all of that really impacts health and well-being. Yes, ma'am, Ms. Brooks.
Thank you, Doctor, for your presentation.
Oh,
I wanted to ask a question about how you select a primary care doctor. I have a good primary care doctor, but I'm asking on behalf of my brother who just turned 70, and I've been trying to show, as the big sister, I've been trying to show him the ropes and how he should select a primary care physician. The one that he has, he says every time he goes to the doctor's office, the doctor acts like he's a new patient that he's never seen him before. And there's no continuum.
mm-hmm.
So I want to encourage him, and he feels he doesn't have any more information when he leaves the doctor than when he came. And I want to encourage him to see a doctor and to continue with a doctor, but I think he may need to investigate a new primary. And I was wondering what your recommendations are on selecting a primary care doctor. He lives in Prince George's County. I live in DC, and I'd see a doctor in DC, and he wants to see one in Prince George's County. That's the reason why he won't see my doctor.
I understand. Well, I'll tell you this. The first thing I'm going to say is it depends for him to look at his insurance and who's in network, because otherwise it's extraordinarily expensive to go out of network. Now, having said that, I don't know if he can rescue, I'll say, the relationship with the primary physician that he has right now by, number one, being extraordinarily transparent and saying, doctor, I've seen you for, this number of years, and I don't feel that we've connected. I think that transparency, number one, would open up the communication if he's willing to stay. But what's most important in selecting the physician is to select someone that he feels comfortable with, having that kind of candid conversation. Every time he goes to the doctor's office, he should have a list of questions that he would like to ask and have answered so that he feels empowered. And I think that's what that relationship is about. So I can tell you, Dr. Callender said, despite my youthful appearance, I've been practicing probably for a good 30 years. And I have patients that I've seen for almost that long. And it's really about developing a relationship with the physician so that they'll feel comfortable having those candid conversations. And I would start right there with exactly what he's feeling. The other thing, sometimes it's helpful to have an advocate with you at your doctor's appointment. If it's not, yeah. So not to challenge, not to threaten, but to
Right,
help that conversation along. And it just
right.
makes it more personable and may be able to move forward that way. I know sometimes everybody may feel a little bit rushed, depending on, what's happening in the office at that moment and that sort of thing. So maybe with the next appointment, instead of asking for that 15-minute, ask for a little bit more time when the appointment is made, and let the office know that, you'd like to have some more time with the physician to have a conversation. I think that might be helpful.
Thank you,
One
doctor.
other thing. Yeah, I'm sorry. One other thing I wanted to point out. Most offices now have a patient portal where you can send questions and ask questions, and it helps to facilitate that conversation a little bit more. I know we get questions. So, for instance, you've had your visit and you forgot to ask something, you can still ask that question in the patient portal and receive an electronic response. And then
Okay.
connect well with. There's nothing better than connecting well with the medical assistant and the nurse and the staff in that office, because they are all health professionals, and they can be very helpful in helping to develop that relationship.
Thank you.
You're welcome. Yes, sir.
Yeah, a couple of years ago, I moved and I had to find a new primary care physician, and so I went on the website for the doctors network, and there was the doctor had a video, the doctor speaking, and so I wanted to pick a doctor that I could connect with the video of the doctor. Like I liked the way he was speaking. I felt there was enough warmth and concern that I was hearing, and I looked at the patient reviews. Generally speaking, uh, the top-rated doctors, there was a waiting list for them to accept new patients because everybody wanted to use them because they were so good. But it was kind of worth the wait to find a doctor that was highly rated and that the patients liked. And so that's how I picked my doctor, and I'm real happy with him.
Very good.
Since there are no more questions, I had a question to you, Dr. McDonald-Pinkett. There's so many vaccinations around. When you get over 65, which vaccinations are actually mandatory?
Okay, so mandatory vaccinations depend on your profession, honestly. So there are no mandatory vaccination. Everyone has an option. Healthcare right now is not mandated by anyone. We know that those who are in healthcare have to take hepatitis B vaccination, have to take the MMR vaccinations in order to practice. So everything right now, Dr. Callender, is still a recommendation. Oh, and COVID. COVID was required in order to maintain your license to practice. The flu vaccination is required in some hospitals, most hospitals, in order to practice in their space. But as far as mandates, governmental or task force mandates or CDC mandates for vaccination, there are none. Healthcare in the United States right now is all voluntary.
Okay, well, which ones are recommended then?
Yes, all right. So recommended vaccinations for adults are COVID vaccination, flu vaccination, RSV vaccination, pneumococcal vaccination, the Zostavax is also recommended for adults. Yes. Now, there are some other specific populations, younger people, that there are different vaccinations recommended for them. But those are ones that are recommended for 60 and above. Mm-hmm.
Thank you.
Have you? Yes, yes. I think I'm due my second Zostavax. That one is 2 vaccinations now. It used to be 1. Now it's 2. RSV is the 1 vaccination.
Elizabeth, go ahead.
Yes, good. Thank you, Dr. Callender. Good morning, everyone. I want to thank for an excellent presentation. It is much appreciated and many notes taken. So I really appreciate that. I have one concern. I noticed that when the COVID epidemic hit, and some of the people were hospitalized and was able to respond to me, I noticed, I asked them, oh, what did they do for you in the hospital? And they said they gave me an infusion. And so I noticed a lot of people that recovered came out the hospital was saying they gave me an infusion. So one person I was very close to, I said, well, what did they tell you was an infusion? And she says, it was vitamins, the B vitamins, etc. Do you have any comments on exactly what is an infusion?
Okay, yes. Excuse me. So, an infusion in general is anything that comes into the body, usually from, the bag that hangs up over the bedside, and you'll see a tubing that goes into a vein. That's an infusion. What I think we're talking about is what the contents of that infusion are. So yes, it is true that some infusions will include B vitamins, multivitamins, IV fluids. Those are infusion. But the infusions specific to COVID are a little bit different. So those infusions include medications to treat the COVID specifically. So I will say this, many people who were in the ICU and in the hospital who received treatment for COVID, especially if they were in the in the intensive care unit, simply don't remember honestly don't remember exactly what happened and what they received. So the medication specific to the treatment of COVID is what the infusion likely that person received. It's so you've heard of the Paxlovid, the medication that people take oral, the oral medication outpatient. So there's a formulation that is can be delivered via IV, and that's what is used to treat COVID by an infusion. Well, thank you. That answers your question.
Thank you very much. Because when his wife called me, the first thing she was excited about was the fact that she was taking the same vitamins and supplements that I was taking, and she didn't get sick at all. So I was glad for that. But, I heard different statements, so that cleared it up very well. And
Yeah.
you know, I encourage everyone to be an advocate. So some of them were reading the chart to see what was in it, and some of them asked the doctor directly. And so I appreciate your comments.
Okay,
Thank you so much, Dr. Pinkett.
you're welcome. I think I saw another hand.
Yeah, I had a
Oh.
question. While we were on the subject of infusion, I got a couple of friends that are getting infusions in their legs. And I'm imagining that infusions come in all types and varieties. So you couldn't probably tell me specifically why these two are getting infusion in their legs. Is that correct?
Okay, so that really depends on where there's access available. So an infusion just means that there is a catheter, like a needle, going into a vein with a substance, fluid, whatever it is, that drips down into the vein. If there is not access available in the upper part of the body, the arm, the hand, then the lower part of the body can be used. Either the leg, in the groin where those big veins are, the femoral vein that comes like in front of the hip. Sometimes that's an area where an infusion, where access to a vein can occur. And so those infusions would be, like you said, in the leg. Sometimes that's not available, and the very small veins and things in the leg, I'm sorry, in the foot can be utilized, but that we try not to do that, but to use a larger access area. So that might be just the area that's available for access.
Thank you for that.
Mm-hmm. Yeah, that doesn't determine what the medication or what the infusion is, just the area of access. Okay.
Yes, Dr. Pinkett, my last question, going back to eye and eye health, my question is about the skin in the eye. I had a visit where I was told the range of the skin in the eye should be a certain range, and that they looked at it and it had decreased, whatever that requirement was. The skin in my left eye had decreased, okay? And so the doctor had several concerns and referred me out. And then they said, my second opinion said that I should have the OCT test so they can monitor that particular eye. And then 2 years later, of course, I worked on myself. 2 years later, they did the eye and they said the skin had increased and they were no longer, and I asked them, what about the OCT test? Because I still wanted that done. And they says, because my skin, whatever that range, it had increased to the range it should be 2 years later, that the OCT test was not required. But because it was diagnosed once, I wanted to continue with the OCT test because I wanted to stay alert. So can you address the skin decrease situation in the eye?
Okay, so I think you may be referring to the fibers in the back of the eye, and that optical coherence tomography, that's the OCT test, looks at the back of the eye to determine what that optic nerve looks like. Now, I'm not exactly sure the reason that it was done, or what those results are. But if it looks like the optic nerve and the fibers to that nerve have responded to the treatment, they may have decided that they no longer need to do the OCT test.
Well, they didn't.
Yeah.
Well, yeah, you're right, because they took pictures of the back of the eye. I always have pictures taken of the back of the eye when I have my annual. And
Right.
because of the type of insurance I have double insurance. So I go to one place so I get my glasses free. Then I go another place because of the fact that I want all my medical records in one place.
Yeah.
But what I did was stuff on my own. nutritional, okay, and nutritional plus supplements. Okay, I did my own advocate reading and everything, and I did nutrition plus supplements, and I worked on myself for 2 years. And when I went back, because as seniors we have to watch, because you can't drive if they diagnose you with glaucoma and all those other things. And of course, I wanted to drive, so I worked on myself. But yes, okay, so that explains that. Thank you.
Okay, you're welcome. And then, of course, you sound like you're a great advocate for yourself. Always ask those questions of the people who are, taking care of you at the time, so that they can explain a little better.
Thank
What and
you.
why? Yeah. Yes, ma'am.
Well, thank you very much. Seems though there's no more questions, and we've had a wonderful presentation by Dr. Shelly McDonald-Pinkett, and can't thank you enough for sharing your wisdom with us. So all I can say is thanks again.
Okay. Thank you so much, and it's a pleasure meeting everyone. Okay. Bye.
Okay, see everybody next week.
All right.
Have a good weekend.
Have a great weekend, everyone.